Welcome, and thank you for joining us today for the pre-application webinar, Improving Outcomes for Pediatric, Adolescent, and Young Adult Cancer Survivors. My name is Jennifer, and I will be your WebEx host. Before I turn over today's presentation to our speaker, Sandy Mitchell, I'd like to share a few housekeeping details. All attendees have been muted upon entry and will remain muted for the duration of the webinar. Please submit your questions throughout the presentation in the Q&A or chat panel and select all panelists from the drop-down. We will ask them on your behalf during the Q&A portion of the webinar. If you need to view live closed captioning, please refer to the link that will appear in the chat box. Questions about specific aims will not be addressed during the webinar. Please also note that this webinar is being recorded. And with that, I will turn it over to Andy.
Great. Thank you, Jennifer, and welcome. We're very glad to have you attending here for this pre-application webinar for RFA 19033, Improving Outcomes for Pediatric, Adolescent, and Young Adult Cancer Survivors. Joining me for this presentation is Dr. Danielle Day. And just in terms of a webinar outline, we're going to talk about background and scope, the goals of the request for applications, some application requirements, and as Jennifer mentioned, some frequently asked questions, as well as your questions out of the chat. So I want to just give us an introduction here to the funding support that has stimulated and motivated this RFA, and it's really from two directions. One is the Beau Biden Cancer Moonshot Initiative, which is an initiative designed to accelerate progress in preventing, diagnosing, and treating cancer by accomplishing a decade's worth of work in 5 years. The Cancer Moonshot provided $1.8 billion in funding that is currently in the process of being distributed. The Beau Biden Cancer Moonshot was informed by the Blue Ribbon Panel, which was designed to minimize cancer treatment's debilitating side effects and to accelerate the development of effective interventions to evaluate and manage symptoms and side effects. When we think about long-term and late effects, I want to just highlight that survivors have significantly more chronic health conditions compared to controls, and that this cumulative burden, as you can see in this slide, increases as the survivor ages. We also see a wide range of organ system complications and comorbid conditions, with CTCA grades 3 to 5 chronic conditions increasing in prevalence, as you can see here, by age, but also with some differential prevalence based on disease site. The STAR Act, or the Childhood Cancer Survivorship Treatment Access and Research Act, is a fairly recently enacted law designed to advance pediatric AYA cancer survivor research and care. The STAR Act authorizes several priorities, but germane to this webinar is research to improve the care of and quality of life for survivors. There's 6 key research areas that are highlighted by the STAR Act to improve the care and quality of life for childhood and AYA cancer survivors. And these include survivor outcomes, barriers to follow-up care, the impact of familial, socioeconomic, and environmental factors on treatment outcomes and survivorship, the development of indicators that we can use for long-term follow-up and analysis of late effects, identification of risk factors, predictors, and the molecular basis of adverse outcomes, and the development of targeted interventions to reduce the burden of morbidity in pediatric cancer survivors. And of particular high priority, health disparities, minorities, and other medically underserved populations are a particular priority for this RFA. So the goals of the RFA, its overall goal is to support the scientific development of interventions to address the adverse biomedical and psychosocial effects in survivors of pediatric AYA cancers. The RFA was first issued in January of this year, January 2019, and we had a first receipt date of March 15, 2019, with 3 awards made. The second receipt date is January 3rd, 2020. When we think about all of the various options to develop new interventions to address pediatric survivorship concerns, it's really important to be thinking about how we can leverage insights from observational studies. And there's a number of these insights highlighted on this slide, both issues around care delivery as well as issues around directly addressing symptomatic and debilitating adverse effects. So when we think about improving care delivery, it's important to note that as survivors transition out of pediatric settings, only a minority are seen by a provider familiar with late effects. Survivors express unmet needs for organized long-term follow-up services. They have increased risk for physical, psychosocial, and behavioral adverse effects, and accelerated aging and physiologic frailty are prevalent. There's a wide range of adverse effects that may be anticipated, and these may be physical, psychosocial, or behavioral, and we've highlighted just a few of these on the slide. So in terms of the aims of the RFA, the aims are to develop feasible, effective, and scalable interventions to address biomedical and psychosocial effects in survivors of pediatric and AYA cancers. This RFA seeks to test interventions to prevent, mitigate, and manage adverse long-term disease and treatment-related effects, including interventions to promote self-management and adoption of healthy lifestyle behaviors. The RFA also seeks applications to develop and test models of healthcare delivery that strengthen coordination, continuity, quality, and improve outcomes. So from that, you can see that applicants to this RFA must be proposing a clinical trial. In terms of the population focus, the population of focus is survivors of pediatric and/or AYA cancers who were diagnosed before age 39 and who are at risk for or experiencing long-term and late adverse physical, psychosocial, and/or behavioral outcomes in the post-treatment period. The interventions may be family-focused, and they may be dyadic interventions that include the survivor together with their parents, caregivers, siblings, or spouse. As I said a moment ago, we are prioritizing applications that address health disparities, minorities, and/or medically underserved populations, and interventions may be targeted at the individual provider or system level and may include multi-level interventions. Potential trial designs appropriate for this RFA really run the gamut from early phase studies to develop and preliminarily test an intervention, through phase 2 and phase 3 studies, which are testing efficacy, to pragmatic trials that will confirm intervention effectiveness in real-world settings, and dissemination and implementation studies, including hybrid effectiveness implementation designs that are designed to look at scale and spread of empirically supported interventions in diverse settings. So obviously, an applicant wouldn't be proposing designs across all of these possible design choices. It really has to be appropriate for the science, but anywhere across that translational continuum would be responsive to this RFA. In terms of the scientific approach, the RFA calls for approaches that address access barriers, specifically geographic distance, literacy, functional deficits, and preferences to engage, because we know that all of these are important for this particular population of pediatric and adolescent young adult cancer survivors. Applicants must propose meaningful proximal endpoints that can be examined within the 5 years of a study award. Mechanistic aims, for example, aims that are looking at how and why an intervention works, also need to address the pragmatic implications of that explanatory knowledge. For example, can that explanatory knowledge be used to amplify intervention effects? Can it be used to optimize an intervention? We very much encourage applications that leverage advances in digital and mobile health solutions. Again, very important to addressing the barriers around geographic distance and preferences to engage. And interventions that are being tested for effectiveness and/or implementation in a pragmatic trial should have already demonstrated feasibility and efficacy. When we think about the potential research topics, there are many, and we've highlighted just a few on the next couple of slides, but there are many others that could be pursued. So some of the topics include developing, testing, and refining interventions to improve access and decision-making about the use of fertility services. interventions to prevent or mitigate late effects like secondary malignancies or comorbidities, and interventions to address persistent long-term effects such as fatigue, cognitive dysfunction, functional impairment, frailty, and emotional distress. We're interested in supporting interventions that mitigate adverse outcomes in subgroups who are at higher risk and most likely to derive benefit from early intervention. We're interested in interventions that expand the reach, adoption, and effectiveness of healthy lifestyle behaviors, and interventions that, together with the pediatric survivor, support caregivers, parents, spouses, and mitigate the adverse sequelae of the caregiving role and improve survivor outcomes. There's also a number of healthcare delivery research program priorities that we are interested to highlight here, and these include models of care that optimize transitions in care between pediatric and adult settings, specialty and primary care settings, and transitions based on geographic relocation. We're interested in care delivery models that strengthen self-management, that improve clinical outcomes and/or access and help to achieve guideline concordant care, as well as care delivery models that are novel approaches to care coordination and communication, and that focus on outcomes such as cost, quality, experiences of care, or other relevant endpoints. And we're also very interested in models that deliver risk-based care targeted to specific subgroups of survivors who warrant more intensive intervention and/or follow-up. So this RFA will be awarding U01s, and we want to say a little bit about the U01 awardee network interactions. Each U01 award will be based on an independent project, and awardees will engage in trans-network interactions and participate in an annual investigator meeting, and the development of budgets should reflect inclusion of these activities. NCI staff role on these U01s will include providing scientific support and coordinating interactions among grantees, as well as facilitating collaboration and information sharing. Applications that are non-responsive to this RFA are summarized in this slide, and it's important to point out that descriptive and observational studies are not responsive to this RFA, and that, as I said earlier, applications must propose the development and testing of interventions in a clinical trial. Applications that propose testing of interventions to address short-term or transient adverse effects of treatment are non-responsive, and similarly, applications that propose development or testing of cancer-directed therapies are also non-responsive. Moving to the application requirements, the application receipt date for this second wave of applications is January 3rd, 2020. We will be constituting a special emphasis panel as before, and I think it's important for applicants to be sure that they address the special review criteria that are highlighted in the RFA, and that includes that the significance of the proposed intervention must be addressed in terms of its ability to reflect a priority need or a priority gap in knowledge for pediatric and AYA survivors, and the proposed work must include relevant and meaningful proximal endpoints. Important to point out that investigators planning to use the NCORE network, whether for cancer care delivery research or cancer control and prevention, must have their application to this RFA approved by NCI NCORE prior to submission. And note, this will require a 6-week lead time. Obviously, as well, investigators should have sought permission from their applicable research base. A letter of intent is due to Danielle Day by December 3rd, and this letter of intent is required both for resubmissions as well as for new applications. Because all of these applications to be responsive must be clinical trials, it's important to note that there are a number of additional application requirements. The NIH requirements for clinical trials research applications were updated in January 2018, and it's important to be sure to learn about and understand the following policies that we've listed here, and we've given you some hyperlinks. It's important to note that the application form consolidates all the human subjects and clinical trial-related information now into one place, And it does expand the information required for applications that include a clinical trial, specifically requiring a Form E. Investigators and staff must receive training in good clinical practice. All sites participating in a multi-site research study must use a single IRB, and all NIH-funded clinical trials are expected to register and submit results to clinicaltrials.gov, and more information about these requirements can be found in the hyperlink associated with the slides. And it's important to note the slides will be made available at the website within approximately 1 week, along with some frequently asked questions. In terms of the application requirements, the budget should reflect the actual needs of the proposed project. However, the budget may not exceed $500K per year in direct costs. Modular budgets, though, are permitted, and up to 5 years of support may be requested. As well, in keeping with the modular budget, fewer than 5 years of support can also be requested as appropriate for the scope of the project. So we just want to conclude before we open up for some questions with just a few highlights from the RFA. So we want to highlight that this RFA is soliciting aims that are testing intervention efficacy in preventing, mitigating, and managing adverse long-term disease and treatment-related effects. And it includes interventions to promote self-management and adoption of healthy behavior. It also includes development and testing of models of healthcare delivery that strengthen coordination, continuity, and quality, and improve outcomes. A clinical trial is required, and the target population can include pediatric and/or AYA cancer survivors at risk for experiencing long-term or late effects, and interventions may be targeted at the individual provider or system level, possibly including multi-level interventions. The approach that is planned in applications to this RFA should reflect that the intervention being tested has significance in addressing a priority need and/or knowledge gap for pediatric AYA survivors. We want to see the inclusion of meaningful proximal endpoints, and investigators should address considerations such as access barriers, geographic distance, literacy, functional deficits, and preferences to engage, as well as leverage digital and mobile health solutions wherever possible. Interventions proposed for testing in effectiveness and/or implementation studies, such as pragmatic trials, must have demonstrated feasibility and efficacy, and applicants planning to use the NCORE network must have prior approval from NCI. So just in wrapping up, we want to say, read the FOA, please, very carefully. Be sure to note the public access and data sharing plans that are required for all projects funded as part of the Cancer Moonshot. And we will, as I said, be posting the webinar and our frequently asked questions at our website within the next week. As well, Dr. Day and I welcome the opportunity to connect with you by phone. Please do reach out to us if you'd like to set up a meeting time to consult about your application or resubmission. And you have our contact information right there. So I think with that, we're starting to see some questions coming in on the chat, and we will just take a moment. I will turn it over to Dr. Danielle Day to moderate the questions. And a few questions were also provided in advance, and so we'll also, if you submit a question in advance, we'll also address that with you.
Okay. Thank you, Sandy. Okay, so one of the first questions that came in ahead of this webinar is, if the proposed application involves a trial in AYA cancer patients with a new tool, can one aim involve the development and/or refinement of that tool?
So thank you for that question. It's important to note, as we said, that a clinical trial is required for this RFA. Within that context, applicants could be proposing an exploratory aim to examine things like minimal clinically important differences, responder analyses, or cut points, but those would have to be completely exploratory aims, not primary or secondary aims. The primary and secondary aims need to be focused on testing intervention efficacy or effectiveness. And as such, and the need to have tools to measure those proximal endpoints, it's fairly unlikely that the design could really meaningfully also develop and test a new tool. So it's possible to include that as a very exploratory outcome, but it would be kind of challenging to frame the application in that manner and still have it be a clinical trial.
Okay, great. Great. So one question just came in about is there a specific range of time since diagnosis and treatment for participants?
So that's an excellent question. And I think there's a couple different things that we would, I think, want to highlight there. First of all, and a lot of the answer to this as well, too, depends a little bit on the patient population, because you may have people who are into the period of the post-treatment for the majority of their treatment, but may be receiving, for example, prolonged maintenance therapy, or prolonged, in the case of breast cancer, for example, prolonged hormonal blockade. And so for those individuals, people can still be receiving part of that cancer-directed therapy, but they should be through their treatment. There is no upper ceiling, though, on the age, and there's no upper ceiling on the time since diagnosis and the time since completion of treatment.
Okay, great. Can you please define a little bit better what you mean by relevant and meaningful proximal endpoints?
Great. So let's just talk about proximal endpoints first, because there's several modifiers in that. So proximal endpoints, what we mean by that is we need applications to be including endpoints that can be measured within the time frame of the project. And this is a challenge in the survivorship area, because some of our endpoints may be endpoints, particularly with mitigation of adverse effects, where the long-term effect might not be seen for 10, 15, or 20 years, but the period of the study is within 5 years. So a proximal endpoint needs to be within that 5-year period. And that's what we mean by proximal. Certainly, that can be a patient-centered endpoint. It could also be a biomarker. It could be a functional endpoint. It could be a radiographic endpoint. There's many different endpoints that could be proposed, but they do have to be proximal. In terms of relevant and meaningful, that is really going to vary based on the intervention, but it should have some kind of mechanistic connection to the intervention in order to serve as a meaningful trial endpoint.
Okay. Can you revisit your definition of survivor for the sake of this RFA?
So we are defining survivor as a cancer survivor. So we are defining an individual as a cancer survivor from the time of diagnosis through the balance of his or her life. And there are many types of cancer survivors, including those, as I indicated earlier, who are living with cancer, and those that are free of cancer. But again, the focus of this award, keep in mind, is to not only be focused on the population of survivors, but also on testing interventions that prevent, mitigate late and long-term effects. And so that's the other piece to sort of keep in mind, is it's not only the population, but the intervention.
Okay, great. We had a question come in about phase 2 and 3 trials. Do those require a RCT design, so a randomized control design?
So it's an excellent question. By definition, a a phase 3 trial would require some unit of randomization to be occurring. In a phase 2 trial, that can either be a single-arm trial or a randomized phase 2 trial. So the inclusion of randomization versus the phase of the trial are really kind of two different things. I think it's better to be thinking about the purpose of each phase of trial. So a phase 1 trial is typically concerned with identifying the components of the intervention, their dosing, their administration, the feasibility and acceptability. And I'm thinking about this in light of behavioral interventions, for example. How acceptable is that? How feasible? What is the uptake of that? How many people drop out? All of that can happen. What's the tolerability of it? All that can happen in a phase 1. In a phase 2, you're beginning to look at the efficacy of the intervention, and that may be done with a single-arm trial. But in today's world, and with some of the challenges of recruiting a rare patient population, it certainly, in many cases, the science really might merit moving to a randomized phase 2 study. And then moving on to a phase 3 study, that would always have to have a unit of randomization to be able to address the goals of a phase 3 study, which is to provide definitive signal around intervention efficacy.
Okay, great. Is it possible to apply for a TU2 award in this arena?
I think, actually, that question I would encourage the asker, please, to email Danielle and I specifically about that.
Okay, great. So I think this is related to a previous question that was asked, but I'll just ask it again. What about refining an intervention prior to testing? Are phase 1 trials that involve development and testing discouraged?
They're not discouraged at all. In fact, we specifically are calling for trials across that full range from phase 1, 2, and 3 trials, as well as we talked about, dissemination and implementation studies, and that may also include pragmatic trials as well as hybrid implementation efficacy trials. So really that full range is something that we are soliciting.
Okay, great. Will this RFA be reissued?
This particular RFA will not be reissued. It's certainly very possible that there will be additional funding opportunity announcements that will be forthcoming, focused on this particular patient population. Pediatric oncology is of high priority for the National Cancer Institute, and we have a number of activities in development to continue to support and accelerate research within this area. I think it's important, maybe just at this point, just to say a little bit about the STAR Act, because that is certainly an important piece of legislation that was introduced back in May and June of 2018. It passed with bipartisan support and was signed into law in June. And the STAR Act does include a number of provisions that are designed to advance research and care for children, adolescents, and young adults with cancer. And among other provisions, the law authorizes and encourages research to improve quality of life and care for survivors, which is what is underlying this particular RFA that we're addressing today. But certainly the NCI, through its Office of Cancer Survivorship, is intending to continue to build on this ongoing commitment to childhood, adolescent, and young adult cancer survivorship research, and will be likely issuing other funding opportunity announcements to foster research applications that align directly with the areas that are outlined in the STAR Act.
Okay, great. Another question from the webinar. Is it possible to propose a phase 1 and phase 2 trial over the 5 years?
So I think, is it possible? Certainly answering this question without knowing anything more about what kind of intervention is being tested in that phase 1, and then in the phase 2, it's really, I think the answer to that is it depends. I think it's important to note that because it's really going to depend on the scope of how much you have to do in the phase 1 and then how complex the phase 2 is to really test the intervention efficacy. It also somewhat depends on the patient population that is being addressed, and as I said, the type of intervention. I think this is the kind of question that certainly Danielle and I would be glad to have an outreach from the individual that asked that specific question, and we can have a more granular conversation about that. It's certainly possible to propose such a study, but whether that kind of study can feasibly be conducted within a 5-year time frame and within a $500,000 direct cost budget is a little bit under question in my mind, but it certainly may be possible to do. I think it does warrant, though, a much more granular conversation than what can be addressed in this webinar.
Okay, great. Next question is, do most recipients of this award treat survivors who are still children?
That's a great question, and I think you'll notice in our both in the RFA and then we highlighted it in our slides, is that the population of interest for this application are survivors of pediatric or AYA cancers who were diagnosed before age 39. And so depending, again, on the intervention being tested and the population of focus, it's possible that some of those survivors who are included in the sample for the clinical trial may no longer be children. If they were diagnosed at a very early age, they may have aged into the adolescent population. Similarly, if they were diagnosed as adolescents or young adults, they may have aged into a early adulthood, middle adulthood stage. The critical pieces are that they are survivors of pediatric or AYA cancer diagnosed before age 39 and at risk for or experiencing long-term and late adverse effects in the post-treatment period. So I think those are the key pieces to keep in mind about the population focus.
Great. Can the intervention address caregivers?
So certainly the intervention can include caregivers, it can include spouses, wouldn't want them to have multiple spouses, the spouse, the caregiver, the parents, or the siblings. And the interventions may be family focused, they may be dyadic, but they do need to include the survivor together with that parent, caregiver, sibling, or spouse.
Great. How many awards will be made?
So it's still unknown exactly how many awards, but we anticipate making between 6 and 8 awards for the RFA over both receipt dates.
Okay, great. Okay, so here's another specific question. What if for an early stage intervention, the intervention is refined and developed during years 1 and 2, and then studied as an RCT during years 3 through 5?
So this is very similar to the other question asked about, is it possible to do a phase 1 and a phase 2 study within a single, application? And so I think I would just highlight again, it depends. Depends a lot on the intervention itself, the state of knowledge about that intervention, how much development is actually required of that intervention, and then what kind of patient population and how easy is that patient population to access and study. So I think that's a very granular question. I think it's certainly, it could be envisioned as possible, whether it can be done in a 5-year timeline, a $500,000 budget of direct costs is not something that we can really sort of say yes or no to on a webinar, but certainly Danielle and I would welcome the chance to talk about an application that might be proposing to sort of develop and refine something in the first couple of years and then study it in either a single-arm trial or an RCT in the subsequent years.
Okay, great. Do applicants that apply to the first receipt date and plan to resubmit for the second receipt date need to submit an LOI?
Thank you for that question. Yes, we would very much need you to submit a second letter of intent, and that's because the letters of intent really help NCI with planning for the volume of applications that need that second receipt date review, also planning for the kinds of scientific expertise that is needed there. So please submit that letter of intent to Danielle by December 3rd, both for new applications as well as those who are resubmitting.
Okay, great. Are interventions that propose changes to the cancer-directed treatment strategy responsive?
No, applications that are focusing on, and I'm not sure how to interpret changes, but I assume that is, improvements to mitigate late and long-term effects, sort of propose modifying the cancer-directed therapy. That would not be responsive. We have a specific notice that's gone out, and that is included in the slides. You can take a look at that. So applications that are focused on cancer-directed therapies are not responsive.
Okay, great. What are the options for revision if the application is new for this round? So if it's an unsuccessful application in this round?
So again, I'll maybe just make more general comments about that, because I think that is a question that is probably best addressed first with Danielle and myself after an application has already been reviewed and we have a summary statement to kind of really guide what would make sense for the next steps. So there isn't sort of a one-size-fits-all. There certainly may, at the time that information is known, there may be other pediatric-focused funding opportunity announcements. There are other pediatric-focused funding opportunity announcements, for example, right now, that individuals might choose to follow on with. There's also options such as the modular R01. So there is and will be a range of options, and a lot of that really depends, again, on the intervention being tested, the population, and perhaps even the sort of late and long-term effect that is being targeted. So that would be something that we would, again, be pleased to be reviewing summary statements with any applicants once those are available, and the focus of that discussion would be sort of where might be the next step, where might we go next.
Okay, great. Can you provide more detail about what is meant by health disparities being of high priority? So,
yes, glad to. So we take a very broad view of what we mean by health disparities. So when we use the phrase health disparities, we are talking about barriers in access or differences in outcomes which systematically and negatively impact less advantaged groups. And this includes, but is not limited to, individuals of racial and ethnic minorities, rural populations, urban poor individuals. Socioeconomic status is a major barrier. There can be geographic, but there can also be health disparities based on health literacy, and then there certainly are barriers based on the population being medically underserved. So we are specifically, because of what's in the STAR Act, as well as NCI's overall interest in being sure that we are addressing health disparities, we have particularly asked for the development and testing of interventions that address these known health disparities and or have been tailored to the specific needs and preferences of minority or other medically underserved populations. And these will be a particularly high priority in selecting projects that are scientifically meritorious in selecting the projects for funding.
Okay, great. We haven't received any additional questions, but Sandy and I both would love to hear from you by email, and we can set up appointments to talk about your specific comments as well. Do you have one more question?
There's one more question coming in here, which is just, again, I'd like to use the NCI NCORE network to conduct my clinical trial. Is there anything special that I need to do? So yes, there are definitely additional steps that you must take if you're proposing to use the NCORE network in your study, and that process is going to take some additional time. First, you need to be sure that you're working with the research base and have been in communication with them. Secondly, letters of intent do need to indicate if you will be using the NCORE network, and then as well allow at least 5 to 6 weeks prior to submitting your application to allow for an opportunity to speak with NCI NCORE staff. And you can be in touch with Danielle and I as soon as possible to let us know you're planning to conduct your proposed study in NCORE, and we will work with the NCI NCORE staff to set up a call and to further outline the process. So we just want to highlight that.
Great. Thank you, Dr. Mitchell, for a great overview on this RFA and answering a lot of the questions we received both before the webinar and during the webinar. As mentioned, please feel free to contact both Dr. Mitchell and Dr. Day with any additional questions you have or any follow-up to questions or answers that were given. We'll be posting the recording and the slides on the website within the next week or so. Please continue to check back for answers to your question or more information.